Thank you very much. So can everybody hear me? Great, fantastic. So fortunately my slides are from my laptop. So here we go. So critical care cardiology, that was the title given to me. It's a very broad subject. I've focused it down to areas where I feel that most of you would be making decisions about patients when you are asked to review patients in the critical care environment. Essentially, these are the sickest patients with a background of cardiological diseases, mainly acute heart failure syndromes or cardiogenic shock. I think the most important question is the patient that you're seeing in the correct center? Should they be at a place where there's equipment, technology, and the right people to look after the patient? And I think the idea is that you have to make sure that the patient is closely monitored, and in terms of the information coming in from the monitoring, actions are taken very quickly because patients deteriorate very, very rapidly. I think it's important that you know your tools that you have access in the critical care environment, mainly in terms of echocardiography, the pharmacological substances available, the devices, and access to the various interventions that you may have either on-site or at your local hospital, secondary center. So this slide comes from the European Society of Cardiology guidelines on acute heart failure management. And essentially, one has to have a very structured way when you're dealing with a patient who has an acute heart failure syndrome. The aim is to improve symptoms, stabilize the hemodynamics of the patient as rapidly as possible and as safely as possible. And the majority of these patients do present with congestion, and a lot of the symptoms are related to congestion. So resolution of congestion is the most important thing. Once the patient is stabilized, then the patient's treatment is focused more on additional disease-modifying drugs, which is where the prognosis can be improved on. So it's very important to identify the reason why the patient has presented in the first place. So just because the patient has presented with an acute heart failure syndrome, the question is, why do they have this acute heart failure syndrome? Is it because they have underlying valvular heart disease which hasn't been detected? Do they have underlying ischemia? Or does the patient have tamponade? Something very simple like that. This is another table from the ESC guidelines. You can see that there are a lot of green class 1 recommendations, but these are things like you have to make sure the patient is having an ECG and an echocardiogram immediately. These are things like you have to make sure the patient's on the critical care unit. When it comes to treatment, there's hardly any green class 1 indication. The closest we've got is a nice study showing that intra-aortic balloon pumps don't work. It's now a class 2B indication, but we still use it. And our focus and attention for managing acute heart failure syndromes and cardiogenic shock has shifted more towards mechanical circulatory support, which I'll go over in a moment. I think one type of information which has been introduced in the vocab is the intermax level that your patient may present. Level 1 is a patient who is presenting in cardiogenic shock, a crash and burn patient who essentially needs attention very, very rapidly. And you'd have to think about percutaneous mechanical circulatory support as soon as possible. And the survival of these patients is quite poor at 1 year, even if they have an LVAD fitted, around 50%. Intermax level 2 are patients who are on inotropes, who are slowly sliding away into worsening cardiogenic shock. And again, these patients are the ones that need to be shifted to a center where they can have mechanical circulatory support. Again, the survival rate of these patients is poor at 63%. So I think the Intermax definitions are important to know and understand, and a way of communicating with your referring colleagues in tertiary centers. So what is cardiogenic shock in the critical care environment? Essentially, it's a low cardiac index, less than 2, associated with poor perfusion, so poor organ perfusion, renal dysfunction, oliguria, liver dysfunction, altered mental state. And it's not necessarily associated with a systolic blood pressure of less than 90. You can still have cardiogenic shock if the blood pressure is in the range of around 100. The commonest reason why people develop cardiogenic shock remains ischemic heart disease, and there is a whole list of non-ischemic reasons why patients develop this too. But often you'll find that patients have a combination of cardiogenic shock and either systemic inflammatory syndrome or associated with sepsis. I think it's very important to detect this and treat at the same time. Another table from the guidelines is this new, well, old concept, but introduced more formally now in the ESC guidelines, is the patient in front of you, stratifying the patient based on whether or not there's congestion or whether the patient has good perfusion or poor perfusion. So the patients are divided into 4 categories: warm and dry, cold and dry, warm and wet, and cold and wet. And the most recent data from about a year ago published, including patients with HFpEF presenting to hospital, the patients who present with congestion and poor perfusion have the worst prognosis. This is the blue line here, compared to patients who are wet and warm, and the dry and warm patients have a better prognosis. You can see that the guidelines again focus on ensuring that cardiogenic shock is diagnosed as quick as possible and action is taken as rapidly as possible in terms of pharmacokinetics, inotropes, and also consideration of the mechanical circulatory options. Again, respiratory failure is another question that you have to ask yourself whether the patient has, and having available to you BiPAP for patients who are developing type 2 respiratory failure, or CPAP for those who are developing type 1. And if the patient is struggling and the work of breathing is very high, the demand for the cardiac output demand for supporting that respiratory level is very high, and you can actually reduce cardiac work by ventilating the patient invasively. The patient at that point is referred on to a critical care area, and the next phase of the assessment is commenced, which is to identify the actual driving reason why the patient's developed acute coronary syndrome, or hypertension, or arrhythmia, which could be the precipitating factor for their acute heart failure presentation. Of paramount importance is to not miss a ruptured ventricular septum or miss acute severe mitral regurgitation or pulmonary embolism, because the treatment for each one of them is extremely different. Good echocardiography is essential in order to pick up these mechanical problems, and as well as the clinical skill of picking up a pansystolic murmur and a frill. So a good echo is very, very important in the critical care environment. We use it on a daily basis to monitor the patients and assess their progress. We often use echocardiography to non-invasively measure the cardiac output and to also ensure that whether or not the patient's heading in the right direction or in the wrong direction. Often we use echo to ensure that the mechanical circulatory devices are well positioned in the inferior vena cava or in the left ventricle, and not altering the function of the valves. I'll go into a bit more detail in a moment regarding this mechanical circulatory support. The guidelines from the ESC have then asked us to look at the patients in the wet, cold and wet manner, or the dry patients, and then decipher whether the patient should be having inotropes, mechanical circulatory support, or diuretics. I think the most important thing is to use medication that you're familiar with in supporting the circulation in terms of inotropic therapy. And I think knowing the medication and having access to certain medication is probably the reason why you may be ending up, for example, using milrinone over levosimendan or dobutamine over milrinone. There's no evidence that any inotrope actually improves survival in any way in this category of patients, as suggested by the level of evidence given by the guidelines. Most inotropes increase heart rate and increase myocardial work. Levosimendan, however, doesn't seem to increase oxygen consumption. However, it has its own issues in terms of giving patients levosimendan. Once you've given it, because of the very long, prolonged half-life, sorry. Okay. Yes. So levosimendan has a very long, has a metabolite which has a very long half-life. So once you've given levosimendan, the medication remains in the patient's body for about 4 to 5 days. So if, for example, you have a patient who's developed an atrial arrhythmia, it's very difficult to control the atrial arrhythmia, because once you've given the levosimendan, it's in the body. It's very difficult to get rid of. However, with regards to milrinone, if a patient develops an atrial arrhythmia, you can switch it off and you have a better chance of getting the patient out of the atrial arrhythmia. Dobutamine is also very similar, shorter half-life. Often when we give milrinone or dobutamine to patients, particularly in renal failure, they may have also a vasodilatory component, so you often end up using vasopressors. And using vasopressors is something which in our training we're not very used to using. However, it's becoming more and more favorable to use vasopressors to ensure that organ function is maintained, which is the main reason why patients die from multi-organ dysfunction. In terms of respiratory support, I've mentioned the importance of BiPAP and also mechanical ventilation. Mechanical ventilation does reduce cardiac output and can allow the heart to recover. I think it's important to be aware of the potential procedures and interventions that you have access to in the critical care environment in the cardiology center, from complex PCI to CRT to presence of ablation for treating patients with intractable VT, which may be the reason why they've ended up in cardiogenic shock. Having surgical access to theatres for repairing damaged or infected mitral valves. So there are many tools available, including transcatheter valve procedures. For example, we would consider doing a mitral clip on patients presenting acutely with severe mitral regurgitation and intractable pulmonary edema and low cardiac output state. Sometimes it's very difficult to offload patients, and we often hemofilter patients or provide them with ultrafiltration. But I think the biggest area which is expanding the most is mechanical circulatory support. And from this slide, you can see that there are 4 main percutaneous mechanical circulatory support devices available: balloon pump, VA ECMO, venous arterial ECMO, tandem heart, and impeller. And from this slide, you can see that the most effective improvement in cardiac output, it comes from VA ECMO and also from tandem heart and impeller. There's a new impeller which has been produced, which can increase cardiac output to about 6 liters per minute. The FDA have given a duration of 6 hours, FDA approval for use for around 6 hours. However, in our institution, we often use this for as long as 2 weeks if we think the patient's going to recover. Balloon pumps have approval for 9 days. However, we have had patients who've had the balloon pumps in for a longer period of time, and the tandem heart for about 3 weeks, and the impeller for about 4 days. Again, these are situations where patients may end up sometimes having the device for a much longer period of time. The good thing about VA ECMO is the fact that you can support the left and the right side of the heart, and also with the tandem heart the same, as well as the impeller. There is a right-sided right ventricular impeller, which is also can be inserted at the same time as a left-sided impeller. And you can see that the sizes of the cannula for VA ECMO are quite large, as well as for the impeller device. And sometimes you need a surgical cut down in order to implant these tubes. There are disadvantages and advantages to each of these mechanical circulatory support devices. As I mentioned, the highest cardiac output comes from VA ECMO. However, VA ECMO comes with its own issues, which I will explain. And balloon pump is probably the least effective, but it's easy to get in, and most hospitals who have catheter labs may have a balloon pump. Very technical to get this tandem heart in. You need a lot of people with a lot of skill set to put this in, as well as via ECMO. An impeller, one can put one in the cath lab to protect high-risk coronary stenting. So it's becoming more and more easy to implant these devices in the cath lab, as well as the intensive care unit. In terms of impeller use for ischemic cardiogenic shock, there isn't, again, any evidence to support its use. At 30-day studies looking at 30-day survival, there's no difference between using impeller or medical therapy. However, these studies are very underpowered. There are several trials which are in progress. Probably the largest one is the Danish-German collaboration, where they're using impeller in patients presenting with STEMI-associated cardiogenic shock, aiming to recruit 360 patients and giving half impeller and the other medical therapy. The primary endpoint of the study is looking at all-cause mortality at 3 months. Sorry, at 6 months. The veno-arterial ECMO circuit looks like this. Essentially, you have a catheter which is placed in the superior vena cava, or around the right atrium, and blood is sucked through the femoral aspect. The catheter is placed in the femoral vein, passed up to the right atrium or superior vena cava. It sucks blood, and then it passes through an oxygen membrane, and then is pushed back into the contralateral femoral artery. So the blood in the aorta passing towards back towards the heart has oxygenated blood. And this can be problematic, which I will explain in a moment. This slide here used the rapid onset and increasing use of VV and VA ECMO throughout the world. In 2016, just over 2,000 ECMO circuits were introduced into patients worldwide. And there are now over 300 ECMO centers throughout the world. So this technology is becoming more accessible. And the reason for that is because the membranes are more durable, the circuits are portable, they can support the left and right heart, as well as if both hearts are failing. The implantation of these catheters has become more easy. It can be implanted in the cath lab or at the bedside. We have a unit which actually goes out and retrieves patients. So in referring hospitals, they put them on VA ECMO and bring them back to our hospital. So we have a retrievable service. So there are financial incentives as well, which are other factors for the explosion and the use of this technology. But I think the most important thing is patient selection, because there's no evidence base that this technology actually works. The VA ECMO can act as a bridge to decision or a bridge to recovery. And the decision is to whether to implant a long-term VAD or consider transplantation of the patient, or to allow the patient to die. So essentially, VA ECMO gives you time to be able to make decisions or allow the patient to recover. And there are studies looking at VA ECMO in patients who've had cardiac arrest. And if there is a return of spontaneous circulation following VF or VT, VA ECMO circuits have been implanted in patients who are down for less than 16 minutes because the brain injury is less likely to have occurred. And the survival rates in some of these studies is actually around 50% or more. Cardiogenic shock due to myocardial infarction, myocarditis, a whole range of reasons why patients could be considered for VA ECMO. I'll give you some examples from our case studies. The patients who do the worst are patients who have ischemic cardiogenic shock, and also those who have had cardiac surgery who are not weanable from the bypass machine. One of the things about VA ECMO is that, as I mentioned, blood is being pushed into the aorta, so the afterload is increased, and what you can see is in this study, as the ECMO flow goes up, the LV-EDP goes up and the LV starts to distend. The afterload also starts to increase as the ECMO flow goes up. So ECMO actually increases afterload. So at the same time as putting a patient on ECMO, what we tend to do at our institution is to put an impeller device in to suck the blood out of the patient. These are some complications of VA ECMO, one of which is reducing cardiac work and distending the left ventricle and essentially causing pulmonary congestion. And in these scenarios, what we tend to do is we give more inotropes, put an impeller device in, and try and relieve the heart. Intracavity clots can also form with the circuits and with the flow of blood in the heart being reduced, as well as intracerebral bleeding and a phenomenon known as Harlequin syndrome, which is just essentially differential deoxygenation in the upper body versus the lower body. So just to give you a break from my my talk, I thought I'll ask you a couple of questions. So the ESC guidelines for acute heart failure from 2016 support the routine use of intra-aortic balloon pumps as a Class 2A indication. Is this true? Is this a yes or a no or a not sure? It's a show of hands because there is no capability to press the button. So those who think it's true or a yes, and those who think it's not true, yes, that's good. VA ECMO can support cardiogenic shock in biventricular failure. Yes, no, or not sure. It's a yes. Which acute heart failure profile is associated with the worst prognosis? Wet and cold, dry, warm, wet and warm. Okay. And VA ECMO may be associated with worsening cardiac function and pulmonary edema. Is that true? Yes, that's true. So, some hopefully interesting cases. This is a patient who is 90 and went to visit their relative in hospital and suddenly collapsed with syncope and low blood pressure, and an ECG showing some features of STEMI. So the patient, who was 90, was rapidly taken to the catheter lab, and you can see that the patient has essentially non-obstructive coronaries and apical ballooning. So this patient has features of Takotsubu's. Never heard of it, a 90-year-old. The interesting factor here is that low blood pressure is associated with left ventricular outflow tract obstruction. And you can see the dagger-shaped continuous wave Doppler. So this patient has cardiogenic shock related to Takotsubu in the form of left ventricular outflow tract obstruction. So what the referring doctors what the cardiologists did who were looking after the patient was to consider putting this patient on an impeller device. So an impeller was inserted into a 90-year-old with Takotsubo, and she made a full recovery within days. Amazing, right? And she went home. So, cardiogenic shock due to Takotsubo cardiomyopathy. Very rare. 1.2% of all cardiogenic shocks are due to Takotsubo's disease. But of the 1.2% who present, there is a high mortality, 15%. And it's very important to perform an echo to make sure that the patient doesn't have left ventricular outflow tract obstruction, which can occur in a quarter of cases. If there is left ventricular outflow tract obstruction, you need to give fluids, you need to give vasopressor, but do not give an inodilator, because that will make the outflow tract obstruction worse. And if that doesn't work, then you have to consider giving mechanical circulatory support to the patient. If they don't have outflow tract obstruction, you could give an inodilator. And if the inodilator isn't enough to support the circulation, then you think about giving mechanical circulatory support. That was case number 1. Case number 2. So this is a 23-year-old gentleman who presented to me on the ward with a new diagnosis of acute heart failure. And he was an electrician by trade. And he liked to go to parties, drink lots of alcohol, and do cocaine. And he presented in this way. So 23-year-old, drug user, alcoholic. Transplant candidate, yes or no? Difficult. Relative contraindication. But when you don't have any organs and you've got a waiting list, it becomes more of a permanent no-no. So trying to convince my transplant colleagues to accept this patient wasn't easy. It took several phone calls. Anyway, on the ward, he decided to go into cardiogenic shock. So this is his liver function, ALT, urea, creatinine. Pretty stable. On the ward, he starts to increase his ALT. So he's got organ perfusion issues, and his urea and his creatinine beginning to go up. So we started him on Mironone. But starting him on Mironone isn't enough. You need to give mechanical circulatory support. So we gave him mechanical circulatory support, and he ended up with a VAD followed by a transplant. Last case, this is a patient, 30-year-old, wanted to commit suicide, taking a deliberate overdose of mercurochrome and sodium azide. These are the chemicals which are used by histopathologists to stain ATP. So essentially he took poison to block his ATP, which is everywhere, his brain, his heart. And the referring hospital picked up the phone on day 4 of his admission and phoned me and said, we have this patient who's taken this overdose. They usually die by day 4. So by day 4, he arrived on the high dependency unit where I worked. And I looked at him, he looked very unwell. 30-year-old, grey, low cardiac output state, cold, clammy, sweaty. And we did an x-ray, very congested. We did this echo. You can see that he's got biventricular failure here. No one's going to accept him for transplant. No way. So what we did is we put him on VA ECMO. We gave him inotropes, Mironone, levosimendan, nitric oxide for the right side of the heart. And we put him on VA ECMO for 10 days. And every day we echoed him. And he improved. And we weaned him. And we sent him home to see a psychologist. So I think the main message that I'm trying to give at the end of this talk is to say acutely unwell cardiac patients are complex. It's multidisciplinary action, which is very important. They require intensive and very responsive monitoring. There's a very poor evidence base. A lot of the stuff I've mentioned so far, there's no evidence for it. It's very costly. But I think there will be evidence soon when there are adequately design trials in terms of power to prove that some of these patients will benefit from these types of treatment, in particular mechanical circulatory support. And I think very, very importantly, I think if you have patients in your institution who you think are slipping into cardiogenic shock, to get on the phone and refer to your center where they have all this available.
Fantastic. Thank you. Right, we're going to have a couple of minutes for questions. I really appreciate you educating us. Just to clarify, VV ECMO, that's for bad lungs, right? You're just oxygenating the blood and putting it back in the veins.
That's correct.
So not something that we are typically seeing. That's more of the ICU folk. Okay, second thing, if you can just give us a step-by-step contemporary management of a big right ventricular infarction and cardiogenic shock. So how should we be managing that in 2020?
So I think we used to be taught how to give fluids first to these patients, but actually giving fluids to these patients actually makes things worse because of the interventricular interdependence. So if we find that someone's gone into right ventricular failure and they have a very, very dilated right ventricle, depending on the blood pressure, then we would give vasoactive pulmonary vasodilators, essentially.
With a Swan, you would put a Swan-Ganz catheter in?
Well, in our institution, we would get help from getting a Swan-Ganz in. It's not the right, well, it's not what we're taught nowadays to use, Swan-Ganz. It's come out of fashion, but when you have this sort of discrepancy between the left and the right, I think you need information about what's happening to the left as well. We would consider using an impeller device in this patient.
In the right ventricle, a right ventricular impeller?
Yeah, right ventricular impeller device in the initial steps, and also consider VA ECMO if there is organ dysfunction and the patient's not responding to milrinone and other types of agents.
And AV synchrony, you know, the patients who are in AFib or complete, I mean, that's important. Would you dual chamber pace?
So often when these patients have very fast heart rates, and you know, our goal would be to try and lower the heart rate down. Often these patients will have a heart rate around 130, 140. We would aim to get it down towards 110, 120, this sort of level.
Okay. Questions from the audience? Someone at the back, why don't you shout it out?
Building on this morning as well, do you think there's a gap in cardiology training in terms of ICU exposure, experience, interaction?
I think it's becoming so specialized that we have now trainees who are doing they're doing cardiology as well as intensive care training. So they'll be triple accredited, acute medicine, cardiology, and also intensive care. It prolongs their training by about 2.5 to 3 years. But I think throughout Europe, the training scheme is now becoming more towards cardiologists who are based in cardiac critical care units. And these will be patients who are, these will be cardiologists who are ECMologists or have access to all this short-term mechanical circulatory support, and also the intensive care know-how of looking after the respiratory side of things, the renal side of things, the filtration side of things. So at the Brompton we have Susanna Price, who's duly accredited in intensive care and cardiology. So she's like one of the unique people, but in Europe there are an increasing number of people who are like that, who have a job which is...
Unquestionably the same in the US, the double board. I mean, the CCUs of old have gone, right? There used to be STEMIs and non-STEMIs. Yeah. They're all home, right? Oh, they're on the floor. Now it's these really multi-comorbid and exactly. LVADs.
I think our ECMO program has rocketed. Our VA ECMO program has rocketed. And I think as the equipment becomes more easy to use and more accessible, more portable, and there are more people who know how to use it, then it'll be available in most secondary care centres too.
Great. Questions? Any more questions? Well, fantastic. Well, thank you again, Ali, for your contribution, your time.